The lower female genital tract may appear to be one continuous passage, but microscopically it is a series of highly specialized tissues. As we move from the vulva to the cervix, the lining changes progressively from true skin to specialized mucosa and finally to mucus-secreting glandular epithelium. Each transition reflects a change in function. Before we can understand disease, we must first understand the normal microscopic architecture on which pathology is built. Before examining each region individually, let us first trace the microscopic journey through the lower female genital tract. We begin at the labia majora, where the lining closely resembles ordinary skin. It consists of keratinized stratified squamous epithelium with hair follicles, sebaceous glands, sweat glands, and abundant subcutaneous adipose tissue, providing mechanical protection to the external genitalia. Moving medially to the labia minora, the tissue begins to change. Hair follicles and subcutaneous fat disappear, while the epithelium becomes thinner and more delicate. Interestingly, numerous sebaceous glands remain despite the complete absence of hair follicles, making this one of the unique histological features of the vulva. Beyond the labia minora lies the vestibule, which marks the transition from skin to mucosa. It contains the external openings of the urethra and vagina, together with the ducts of the greater vestibular or Bartholin, glands, and the parourethral or Skene glands. The vagina is lined by non-keratinized, stratified squamous epithelium, specialized to withstand friction while maintaining flexibility. Finally, at the cervix, this squamous epithelium abruptly changes to mucus-secreting simple columnar epithelium within the endocervical canal, forming one of the most clinically significant epithelial junctions in the female reproductive tract. The vulva forms the external female genitalia and serves as the first line of defense for the reproductive tract. Although it appears as a single anatomical unit, it is composed of several distinct structures, each adapted for a specific function. These include the labia majora, labia minora, vestibule, and the associated vestibular glands. Their microscopic architecture varies considerably, reflecting their different protective, secretory, sensory, and mechanical roles. Let us begin with the labia majora. Labia majora. The labia majora are two prominent longitudinal folds of skin extending from the mons pubis to the perineum. Histologically, they closely resemble ordinary skin and are lined by keratinized stratified squamous epithelium. Beneath the epidermis lies a dense irregular connective tissue dermis rich in collagen and elastic fibers. Deep to the dermis is a thick layer of subcutaneous adipose tissue, which gives the labia majora their characteristic fullness and provides cushioning against mechanical trauma. Like normal skin, the labia majora contain hair follicles, sebaceous glands, eccrine sweat glands, and modified apocrine glands. These skin appendages help maintain the integrity of the external genitalia, while bacterial metabolism of apocrine secretions contributes to the characteristic genital odor. The connective tissue is richly vascularized and innervated, containing abundant blood vessels, lymphatics, and sensory nerve endings. Smooth muscle fibers, continuous with the dartos muscle of the perineum, may also be present within the deeper connective tissue. Together, these features make the labia majora well suited for mechanical protection. The keratinized epithelium resists friction, the adipose tissue absorbs mechanical stress, and the skin appendages help maintain the local tissue environment. Clinically, the presence of hair follicles explains conditions such as folliculitis and ingrown hairs, while the apocrine glands are the site of diseases such as hidradenitis suppurativa. Because the labia majora are essentially modified skin, they may also be affected by common dermatological disorders, including eczema, psoriasis, lichen simplex chronicus, and cutaneous malignancies. Immediately medial to the labia majora lie the labia minora. Although separated by only a narrow groove, their microscopic structure is strikingly different. Unlike the labia majora, they are hairless skin folds that lack both hair follicles and subcutaneous adipose tissue, making them thin, highly vascular, and remarkably flexible. They are lined predominantly by non-keratinized stratified squamous epithelium, although mild keratinization may be present laterally where they merge with the labia majora. This thinner epithelium maintains a soft, pliable surface while providing protection against mechanical stress. Beneath the epithelium lies a delicate lamina propria composed of loose connective tissue rich in elastic fibers and blood vessels. The absence of subcutaneous fat, together with this rich vascular supply, accounts for the characteristic thin appearance and pinkish coloration of the labia minora. A distinctive histological feature of the labia minora is the presence of numerous sebaceous glands despite the complete absence of hair follicles. Unlike most sebaceous glands in the body, these open directly onto the epithelial surface, where their lipid-rich secretions help lubricate the vulva and reduce friction. The labia minora are also richly innervated, containing free nerve endings and specialized mechanoreceptors that contribute to both protective sensation and sexual function. Functionally, the labia minora protect the urethral and vaginal openings, help maintain vestibular moisture, reduce friction during movement, and form an important barrier against external pathogens. Their highly vascular connective tissue also allows considerable distensibility during sexual arousal and childbirth. Clinically, the absence of hair follicles explains why folliculitis does not occur in the labia minora. However, the sebaceous glands may give rise to Fordyce spots or small sebaceous cysts, both of which are benign. Because the epithelium is thin and delicate, inflammatory disorders and traumatic injuries also occur more readily than in the keratinized labia majora, vestibule. Medial to the labia minora lies the vestibule, the region where external skin transitions into the mucosal lining of the lower female genital tract. It contains the external urethral opening, the vaginal orifice, and the ducts of the greater vestibular Bartholin glands and paraurethral skin glands. The vestibule is lined predominantly by non-keratinized stratified squamous epithelium. Unlike the surrounding skin, this epithelium lacks hair follicles and is adapted to remain moist while resisting mechanical stress. Beneath it lies a highly vascular connective tissue rich in elastic fibers, allowing the tissue to remain soft, flexible, and distensible. The vestibule is also richly supplied with blood vessels, lymphatics, and sensory nerve endings, contributing to both protective sensation and sexual function. An important feature of the vestibule is the presence of its associated exocrine glands. The Bartholin glands are paired compound tubuloalveolar mucus glands located deep within the superficial perineal pouch. Although the glands themselves lie outside the vestibule, their ducts open on either side of the vaginal orifice. Their mucus secretion lubricates the vestibule, particularly during sexual arousal. The skin glands lie adjacent to the distal urethra and open near the external urethral meatus. They are regarded as the female homologs of the prostate and may produce prostate-specific antigen PSA and prostatic acid phosphatase PSAP. Together, the vestibular epithelium and its associated glands protect the entrances to both the urinary and reproductive tracts while maintaining lubrication and mucosal integrity. Clinically, obstruction of the Bartholin duct may lead to a Bartholin cyst, which can become secondarily infected and form an abscess. Disorders of the skin glands are much less common. Vagina. Having examined the external genitalia, we now enter the vagina. Unlike the vulva, which is covered largely by skin or modified skin, the vagina is a fibromuscular organ lined entirely by mucosa. Every component of its wall is adapted to perform two essential functions, withstanding mechanical stress while maintaining a healthy protective environment. The vaginal wall consists of three layers: the mucosa, muscularis, and adventitia. Unlike many hollow organs, it lacks a true submucosa, allowing the mucosa to remain firmly attached to the underlying muscle while preserving remarkable flexibility. The mucosa is lined by non-keratinized stratified squamous epithelium. Its cells mature progressively from the basal layer through the parabasal and intermediate layers to the superficial squamous cells, which retain their nuclei and do not undergo keratinization. This organization produces a moist, flexible surface capable of resisting repeated friction. During the reproductive years, estrogen stimulates epithelial proliferation and promotes the accumulation of abundant glycogen, particularly within the intermediate and superficial cell layers. As these cells are naturally shed, resident lactobacillus species metabolize the released glycogen into lactic acid, maintaining the vaginal pH between 3.8 and 4.5. This acidic environment suppresses many pathogenic microorganisms while supporting the normal vaginal microbiota. An important point to remember is that the vagina contains no glands. Despite remaining continuously moist, it produces no intrinsic glandular secretions. Instead, lubrication is derived primarily from transudation of plasma through the richly vascular vaginal wall, supplemented by cervical mucus and secretions from the Bartholin glands. Beneath the mucosa lies the muscularis, composed predominantly of smooth muscle arranged into indistinct inner circular and outer longitudinal layers. Together, they provide the strength and distensibility required during sexual intercourse and childbirth. The outermost adventitia consists of dense fibroelastic connective tissue containing abundant blood vessels, lymphatics, and nerves. This layer anchors the vagina to surrounding pelvic structures while preserving its mobility. The vaginal epithelium changes significantly with hormonal status. During the reproductive years, estrogen maintains a thick, glycogen-rich epithelium that supports the normal acidic environment. Before puberty and after menopause, declining estrogen levels produce a thinner epithelium with less glycogen, reduced lactic acid production, a higher vaginal pH, and increased susceptibility to irritation, infection, and atrophy. Clinically, because the vagina is lined by non-keratinized stratified squamous epithelium, most primary vaginal epithelial lesions are of squamous origin. Normal hormonal changes in the epithelium are also fundamental to the interpretation of vaginal and cervical cytology. The vagina beautifully illustrates the relationship between structure and function. Every component, from its multi-layered epithelium and protective microbiome to its smooth muscle and fibroelastic adventitia, is specialized to provide protection, flexibility, support, and defense against infection. Having completed the vagina, we now arrive at the cervix, where one of the most important microscopic transitions in the female genital tract occurs. Here, the protective squamous epithelium gives way to mucus-secreting simple columnar epithelium, creating an epithelial junction of immense clinical significance and laying the foundation for understanding cervical cytology, metaplasia, HPV infection, and cervical neoplasia, cervix. The cervix forms the lower cylindrical portion of the uterus and is divided into two histologically distinct regions, the ectocervix and the endocervical canal. Although they are continuous, their epithelial lining differs because each region performs a different function. The ectocervix, which projects into the vagina, is lined by non-keratinized stratified squamous epithelium. Similar to the vaginal epithelium, it provides protection against the mechanical stress of intercourse, childbirth, and exposure to the acidic vaginal environment. Unlike the vagina, however, it contains relatively little glycogen. Within the endocervical canal, the epithelium changes abruptly to a single layer of mucus-secreting simple columnar cells. These cells form numerous deep folds and branching endocervical glands, increasing the secretory surface area. The properties of cervical mucus vary throughout the menstrual cycle. Under the influence of estrogen, it becomes thin and watery, facilitating sperm transport during ovulation. Under the influence of progesterone, it becomes thick and viscous, forming a protective barrier that limits the passage of microorganisms and sperm during the luteal phase and throughout pregnancy. Cervical mucus therefore plays an essential role in both fertility and protection. The point where the squamous epithelium of the ectocervix meets the columnar epithelium of the endocervical canal is known as the squamocolumnar junction, one of the most clinically important regions of the female genital tract. Squamocolumnar junction. The squamocolumnar junction SCJ is the site where the protective squamous epithelium of the ectocervix meets the mucus-secreting columnar epithelium of the endocervix. Rather than remaining fixed throughout life, its position changes with age, hormonal status, pregnancy, and cervical growth. This dynamic region is particularly important because it is highly susceptible to epithelial remodeling. As a result, it is the site where the vast majority of precancerous cervical lesions and cervical carcinomas arise. For this reason, the SCJ is the principal focus of cervical screening and forms the foundation for understanding cervical cytology and HPV-related disease. In the next module, we will examine this region in detail, including the transformation zone, squamous metaplasia, HPV infection, cervical intraepithelial neoplasia CN, and the development of cervical carcinoma. Summary: the lower female genital tract is not lined by a single type of epithelium. Instead, it forms a continuous histological transition from the keratinized stratified squamous epithelium of the labia majora through the modified mucosa of the labia minora and vestibule to the non-keratinized stratified squamous epithelium of the vagina and ectocervix, and finally to the simple columnar epithelium of the endocervical canal. Each transition reflects a change in function, and understanding this normal microscopic organization provides the foundation for recognizing disease.